Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient had a dislocated IOL that was in the ciliary sulcus, and the patient had chronic and recurrent CME. The patient was being seen down in the Atlanta area and being treated by a retinal specialist. And then the patient sought me out for a second opinion. And this patient's a very reasonable guy. He doesn't really want refractive lens surgery. He just wants to not have to see the retinal specialist so often because he's been dealing with the CME for so long. And so he's just hoping that he can have the CME resolved, and he's hoping that the lens surgery will just provide him some long-term stability without having to see so many doctors and so frequently. And so here you can see I'm just tapping the surface of the eye. You can see the lens is dislocated, but look at that. When I touched the sclera, you saw the lens moved. And so this patient has a very deep chamber, and as I'm pushing on the eye, you can see the lens is moving. So go ahead and mark the limbus, and then I'm trying to find 180 degrees apart from the other mark. And then I'm using a caliper set at 2.5 millimeters, and I'm making an indentation mark radial to that first mark at the limbus on either side. And those marks are going to be for my needle placement through the sclera. Always make sure that the surface is dry. Using a pre-marked cannula, I'm marking 2.5 millimeters back and 2 millimeters adjacent to the mark. And so on the right side, it's a backwards L, and on the left side, it's going to be a backwards 7 configuration. So I use a cotton tip also to steady my hand, which is nice. And so by steadying my hand, I'm able to get a nice circular mark here. So I'll go ahead and make my incisions, my paracentesis incisions, which will help me for the explantation of the lens. And this is for the externalization of the leading haptic. Intracameral lidocaine, and then intracameral epinephrine to stabilize the pupil. You can see the lens is wobbling. So this is a very unstable lens in the ciliary sulcus. Injecting some dispersive viscoelastic to fill the anterior chamber and coating the corneal endothelium. And then this is the 3 millimeter keratoma incision. This is a patient's left eye, so I'm working superatemporally here. And my incision is supratemporal. This is a 25 gauge needle bent about 80 degrees with the bevel facing to the right. That's going to go through the contralateral incision. This is the right side needle. I'm bending it about 9 millimeters from the tip. And then this is the left side needle, and I'm bending it at the hub right here. So I'm going to use forceps and scissors to cut this lens out. In my right hand is the scissor. I'm just, with the teeth closed, I'm getting underneath the optic, lifting it up, and then grasping the optic with the serrated forceps in my left hand. I begin to cut the lens with the scissors, bisecting it completely in half. I'm switching instruments on my right hand to forceps to grasp the haptic there. Grabbing the haptic up and then delivering that left side half of the lens, and then grasping the other half of the lens there. So that went pretty easily. This is the incision for my 20 gauge Lewicki AC maintainer. It's a pretty tight fit, which is what you want. And then I'm going to place the Sensar lens into the cartridge. And this is very important. You have to make sure there's viscoelastic there. Make sure the barrel's filled with viscoelastic, or at least BSS, so there's no bubbles. And you want to just push down on each side, making sure that the optic edge is underneath right there, that little rim. And you can feel that it's underneath and in the rim. And you want to make sure that leading haptic comes out straight. It can't come out curved because it's going to kink and damage the haptic. So that leading haptic has to come out straight through the barrel. So this is a 25 gauge needle. I'm placing it, it's pre-bent. I'm placing it through the contralateral limbal incision, and it's going to allow me to atraumatically and gently externalize the leading haptic of this Sensar lens. Remember, the Sensar lens has very delicate PMMA haptics. My assistant is going to help push the lens forward. As the haptic comes out, I dock it on the bevel of the needle, which is facing to the right, and it very nicely and smoothly comes out. I take over and start to deliver the optic, and then deliver the trailing haptic, making sure it's facing the right side. Injecting some more viscoelastic to protect the cornea, grasping the limbus here, and this is the needle. I'm tunneling 2 millimeters and then diving straight down, staying in that same plane. I don't rotate until I'm all the way through because you don't want to hit the ciliary body. And once you can see that, again, the bevel is facing towards me on the right needle, grasping the haptic with microforceps and very gently, and this is important, you want to make sure that the haptic and the needle are directed parallel towards each other. So I'm going to dock the haptic on the bevel of the needle. Sometimes you have to turn the needle and rotate it to straighten it out to approach the haptic, like just right there, as you saw right there, making sure they're directly parallel to one another, and then you're able to cannulate the haptic very easily and very gently without any struggle whatsoever. Disengage the needle off the syringe, internalize the leading haptic with microforceps, grasping the incision again with the right hand. With the left hand, I go ahead and start tunneling the needle through the sclera, 2 millimeters, and then diving down. Again, I'm still in that same plane. Don't rotate until you're through, otherwise you'll hit the ciliary body. With the right hand, go ahead and use microforceps to try to dock the haptic on the bevel of the needle. You can see here, I'm trying to dock, it's not straight. So look, with my left hand, I turn my hand just ever so right there. I turn the needle towards me. I'm able to dock it nicely. It goes right in, and I start to cannulate through the needle very easily here with the haptic. Again, very gentle technique. And with the PMMA haptics with the Sensar lens, they're actually really nice and tacky. So when I pull the needles out, you want to pull the left needle towards you and the right needle away from you in the direction in which it came. But as I pull, you can see the left side needle comes out, but it's very tacky and it doesn't tend to slip back into the eye. So I love that aspect of this Sensar lens. Cauterize the tip, create a small flange on the left side, do the same thing on the right side, making sure I pull it out with my right hand and using forceps to grasp the haptic as it comes out with my left hand, and then cauterizing the tip to create a small bulb. So they'll go ahead and push the haptics flush to the sclera and then reapproximating the conjunctiva. Because you have a nice shelf, remember, you see how much I tunnel. The tunnel is so critical because if you don't have that tunnel, you don't have an adequate shelf, and therefore you don't really have very good IOL support. You don't want a 2-point fixation. You have actually a 2-plane fixation this way. So then I'm using the mechanical IA. You can see I used the IOP. I dropped the IOP significantly, so I'm not pushing too much fluid in. Make sure all the viscoelastic is removed from the anterior chamber and off the cornea. I always place a tendonylon suture when I'm doing these cases. This patient did have a full vitrectomy before, and so that's why you notice I didn't use any trocars or anything like that. If a patient had a full vitrectomy by a retinal specialist, then you don't really have to go and put trocars in and do vitrectomy. And so this case, I didn't have to do a vitrectomy. It was simply a lens exchange, placing the Sensar lens, again, using my modified Yamane technique, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.